So, welcome everybody to this third in our Lunch and Learn series. And today we'll be talking about the Northwest Coast Clinical Network Clinical Practice Summary. I'd like to welcome our speakers, Dr. Kate Stewart and Dr. Laura Chapman, who are both consultants in palliative medicine. I'm sure they'll introduce themselves when they start. And without further ado, I will hand over to Kate.
Thanks. As been said, my name's Kate Stewart. I'm one of the consultants in palliative medicine. I'm based up in Preston, in the hospital here. If you just go to the next slide, please. So the hope is that we're going to use this session this afternoon just to go through a little bit about what the clinical practice summary is, what its role is, and touch on some of the types of guidance. We're not going to have time to go through all of it in detail. It's quite a long document, but hopefully it should give you a flavour of what's in it and be helpful in terms of making it feel usable. So if we go to the next slide. So the clinical practice summary is a document. It's been around for a few years. We're doing this because we updated it earlier this year, but it's had previous versions that have been around for a while. And so hopefully it's familiar to some of you. It's it's clinical guidance for those who don't work within specialist palliative care. Although you'll probably find that a lot of our specialist palliative care teams use it certainly as an initial starting point. It's not designed to replace advice from our experienced clinicians. So if you're not sure what to do, or you've got somebody whose symptoms are particularly complex, please do get in touch with your local palliative care team. It's evidence-based. We've used evidence where there is evidence, but as some of you may be aware, there's not huge amounts of evidence for some of what we do in palliative care. And so a lot of what's in this guidance is consensus. So you'll see if you scroll right to the bottom of the document, there was a long list of clinical staff from within palliative care who had input into the development of the document. And so a lot of what's in here is a consensus of what we think is currently best practice and safest practice. But you might just find that there are individual circumstances where people choose to do something different, and that's absolutely fine. So if we go to the next slide, Kath, thanks. So for the first few minutes, we just thought we'd touch on some of the key symptoms. So as I said, it's clinical guidance, and a big chunk of what's in there is guidance on how to manage common symptoms that our palliative care patients experience. And there's quite a lot of information in there about how to assess pain, our approach to managing it. There's some information in there about total pain, and the psychological, spiritual, social elements that feed into people's experience of pain. There is some guidance in there around neuropathic agents, so options for managing different types of pain. I did just want to highlight the opioid conversion tables, though, that we've put in to this updated version. They're slightly different to what was in the previous one, and we've separated out the conversion between morphine and oxycodone and the conversion between patches, just to try and make it as clear as possible for people when they're using it. So you'll see on this table, we've got a central column that's got the total oral morphine dose that somebody uses in a day, so in 24 hours. And best practice would say always go back to that total oral morphine dose that somebody's used in 24 hours when you're converting between any type of opioid. So if somebody's on, for example, a syringe driver of 20 milligrams of morphine, you'll be able to see the kind of third line down on that. If you're then thinking, oh, I really need to start them on oral oxycodone twice a day, for example, because their renal function's changed, you would go back through the oral morphine total daily dose, so 40 milligrams of oral morphine in total in 24 hours, and then would see that that is 10 milligrams twice a day of MR oxycodone. There are times, and you'll see this with the little red asterisks that are on there, particularly with oxycodone, where there isn't an exact number that you can reach because of you're dividing by two. So depending on the clinical circumstance, you'd need to use your clinical judgment about whether you go for a slightly lower dose and encourage them to use PRNs to work out is that right, or whether you might go for a slightly higher dose, particularly if you think somebody's pain's not particularly well controlled at that point. If we go to the next slide. So the other bit that I was just going to highlight is the conversion for patches. And actually, there's quite a lot of information within the clinical practice summary on how we use patches, when to use patches. We would always suggest going for the oral opioids as the first option, unless there's a reason to go for a patch. You'll be able to see from the table that there's quite big jumps in that total oral morphine daily dose as you go up between different patches, particularly as you go up between different strengths of fentanyl patch. And it does mean that it can be quite tricky to titrate. And so we would, in an ideal world, you want to know exactly how much morphine somebody was needing before you went for a patch, rather than trying to change the patch every few days. The other thing that's in the clinical practice summary is some information on things like how to apply the patches and information to give people when they're taking them off. So it's really important, for example, to fold them in half because there's still a reservoir of drug within the patch when they're taken off. And obviously we don't want that getting stuck to wildlife or a small child when it goes in the bin. So there's information like that within the clinical practice summary as well. But for this, you would work out, again, what somebody's total oral morphine daily dose is, and then you can read across to the appropriate either buprenorphine or fentanyl patch dose. We haven't in this specified any of the brands. There are lots of different brands, and particularly for buprenorphine patches, the brand that you're using will influence how frequently the patch needs to be changed. So when you're prescribing them, it is quite important to prescribe the brand that you're wanting to use, and then specify how frequently you want the patient to be changing that. If we go to the next slide. So the clinical practice summary does contain quite a lot of information about other symptoms. As I said, we're not going to go through all of them in detail now, but there are a couple that I was just going to touch on. So if we go to the next slide. So this just gives you an idea of the kind of information that we include for the symptoms. So this is the page on nausea and vomiting. I've tried to put in bigger letters exactly what each section is doing, but you'll see that there's advice on kind of reversible causes of nausea and vomiting to consider. There's a section on which antiemetic to choose as first line, depending on what you think the cause of somebody's nausea and vomiting is. And we would say wherever possible, we would want to try and think through what is causing somebody's nausea and vomiting, because that can have a really significant impact on which antiemetic we go for. And then there's a section on specific considerations for when it comes to antiemetics for different clinical circumstances. So, for example, for the patient who has raised intracranial pressure or Parkinson's disease or severe heart failure, and there is actually a separate section within the guidance on how to manage bowel obstruction. So there's a whole page dedicated to managing those patients with bowel obstruction. And then if we go to the next slide. So the other section I was just going to highlight is the one on constipation. If you used to use the old version of the clinical practice summary, you might remember there was quite a long kind of complicated table around which laxative to choose in what circumstances. We've really tried to simplify that in this version. And so what we've done is given a kind of first line option, a second line option, and a bit of guidance around rectal treatments. We would generally encourage people to use a combination of a stimulant and a softener, provided somebody can tolerate both of those. And stimulant-wise, we tend to go for Senna or bisacodyl. Softener-wise, we often go for Docusate first line. We tend to find that macrogols often aren't particularly well tolerated in our patient group just because of the volume that they have to drink. You have to be drinking quite a significant volume of fluid in order for an osmotic laxative to work, because it works by holding that fluid in the gut. And so we would generally advise those as being second line options. The other thing that we have changed slightly in this section, you may remember that it suggested for opioid-induced constipation using naloxegol before. We've now changed that to say use any Pamora. We know that different areas can get hold of different ones, but the NICE guidance says that if you've tried a traditional laxative and you think somebody's constipation is opioid induced and the traditional laxative hasn't improved that constipation, that they would advise switching to a Pamora relatively quickly. And I think we would encourage that, provided there isn't a contraindication, that we are using those Pamoras, so naloxegol, naldehyde, a lot more than we perhaps have done previously. Next slide. Yeah. So I'm going to hand over to Laura now for the second half.
Thanks, Kate. Thanks everyone for joining us. I'm Laura Chapman. I'm a consultant in palliative medicine. I'm based at the Marie Curie Hospice in Liverpool. So I'm going to carry on. I'm just going to, again, as Kate has done, just sample a few areas of the guidance just to give you a flavour of it. So another area that we looked at was palliative care emergencies. So you can see the emergencies that we've included in that. Just to focus in on, if you can go to the next slide, please, Kath. So seizures is one of the areas that we've made a few changes to, if you were familiar with the previous version of the guidance. So at the top there, we've broken that down a bit, just into very acute seizure management, so the first few minutes, and then first line treatment, so for 5 to 15 minutes. And we've included details on just the basics, really, ensuring airway is secure, administering oxygen, looking for any treatable causes such as hypoglycemia, and then the immediate seizure management, and advice to seek specialist advice, especially if the patient's already on anti-epileptic medicine. Then moving on to that second line management. And there's a distinction here between whether we think the patient is possibly in the last days of life or not. So this is sort of 15 minutes plus the commencement of seizure activity, and around deciding if transfer to hospital for emergency management is needed or appropriate, or are they going to remain in the current place of care. If the patient is in the last days of life, just looking at what they've required in terms of benzodiazepines, and considering whether we'd actually commence subcutaneous infusion with a starting dose of 10 to 30 milligrams of midazolam over 24 hours. If they're not in the last days of life, then we give some information here about what treatment options there might be, depending on whether they're already on an anti-epileptic or not. And then moving on to the lower part of the guidance, the management of refractory seizures and treatment of underlying causes, so such as dexamethasone for intracranial edema associated with brain metastases. If you move on to the next slide, please, Kath. Thanks. So hypercalcemia is one of the other emergencies that we've included. A lot of it hasn't actually changed. So we've given some information about particularly the cancers that are likely to predispose a person to developing hypercalcemia. what the symptoms might be, and obviously what sort of blood level we're looking at for hypercalcemia, but there is going to be some variation across different areas. That the clinical assessment is absolutely crucial in determining whether treating this issue is appropriate, because it can be a pre-terminal finding. And just really focusing in on what's the goal of treating it, and it's to improve the clinical symptoms. The bit that's been added in, so there's a new section on medications to review. So that includes some medications that might actually be further elevating the calcium, such as calcium supplements and antacids, and then also looking at things like non-steroidals, ACE inhibitors, as these are potentially going to worsen any renal injury that might be concomitant with this. We've also mentioned lithium, so we know that being on lithium can in itself influence calcium metabolism, so it can increase the resorption of calcium from the urine and also increase the release from bones. So it's important to liaise with psychiatry if we feel that might be contributing. And also around thalidomide and any anti-angiogenic medication. And then we move on to recommendations around treatment. And again, obviously we want to rehydrate somebody with IV fluids prior to treating them for hypercalcemia. But again, this comes down to just your clinical judgment about how dehydrated the person is and how much you think they are actually able to tolerate rehydration. We've got recommendations around intravenous bisphosphonates. That's going to differ between different local formularies, and also talking about denosumab. So that's an off-label treatment for hypercalcemia that we can sometimes use instead of bisphosphonates in patients where we're concerned about their renal function or where the hypercalcemia is resistant to bisphosphonate treatment. And I mentioned at the bottom there of one of the potential serious side effects. So it is rare, but I'm sure a lot of us have seen it, and that's osteonecrosis of the jaw, and the importance of counselling patients on that. So if we can go to the next one, please, Kath. Thanks. So the next section to look at is the care in the last weeks or days of life. So we've broken that down into key priorities: diabetes management, symptom control of the main 5 symptoms, and the use of continuous subcutaneous infusions. So the next slide. So I'm just going to talk through the beginning of the care in the last weeks or days of life. The first box you can see there is just about recognising that the person may be in the last weeks, days, or perhaps hours of life, and the communication that goes along with that, with the patient and the people important to them, and the importance of creating an individualised plan of care. And I'm sure everyone's familiar with that. That includes escalation plans, place of care, discussions around oral food and fluid intake, perhaps stopping observations or investigations, and looking at the appropriateness of clinically assisted hydration or nutrition, as well as the anticipatory medication. One bit that has changed slightly, so we looked at the approach to diabetes management, so I've included this here. And of course, it is just a change of approach as somebody's approaching the end of their life. So we've talked about the assessment and description. These are often people who have had diabetes for many, many years, and they and their families will be absolutely focused, perhaps on tight blood sugar management. So there's a lot of communication required here, just around the change in focus, that actually what we're trying to do is avoid symptoms due to either hypoglycemia or hyperglycemia. That And for that reason, we're going to reduce our monitoring of the blood glucose, both in terms of how we do it and how frequent. And we're also going to amend the type of management. So we're going to try and keep invasive tests to a minimum and just look out for the symptoms that might show us that actually we need to change our management plan again. So we've broken this down into type 2 diabetes, both with or without insulin. So it's relatively simple if somebody is diet controlled or just on metformin. And we really just need to stop monitoring blood glucose, but of course, keep an eye out for any worrying symptoms. If somebody has type 2 diabetes on other tablets and or insulin, then it's about stopping the oral hypoglycemics. Consider stopping the insulin if they're only on a low dose. And if it is to continue, maybe switch that to a once daily long-acting insulin, such as Lantus, with a 25% reduction in the daily dose. Things are a bit more complex for people with type 1 diabetes. So this group are generally going to require ongoing insulin therapy in order to prevent problematic hyperglycemia right up until the end of life. So we probably look at continuing a long-acting insulin in the morning, again, such as Lantus, and again with a 25% reduction in dose, and stopping any short-acting insulin. We recommend checking blood sugars once daily at tea time, and we've got some plans there for how we might alter that management according to blood sugar changes. Next slide, please, Kath. All right, I think it's back to you.
Okay, thank you both for those insights into the changes. The clinical practice summary full document is available on our website, and I just wanted to highlight a couple of other things that are also available on our website to support staff who work in palliative and end-of-life care services. So we have an early clinical search tool. It's called EoL because the acronym relates to some of the steps. The full I'll not go through the full search tool. You will be able to find it on the website. But essentially, it's works in electronic systems in primary care to identify people who may be in the last year of life. We also have tools for care home staff. Shadow was developed especially for care home staff to improve their confidence and ability to recognise residents who may be approaching end of life. We've got information on personalised care planning. We've got the Northwest Model for Life Limiting Conditions, which is a best practice guide. And we've also got a page on education, so where you can find some of those education programs that would help support people who are looking after palliative end of life patients. We've got the Mayfly program, which is an advanced care planning and communication skills 1-day training, very well rated. And quite a lot of our education hubs are offering Mayfly training across the patches. We also have a new education prospectus for our Cheshire and Mersey staff. So please go and check that out. And there's a lot of information in there. And in the Lancashire South Cumbria area, we're working on web resources to support those education pages.